right, today we're tackling a topic that is just incredibly high stakes, providing anesthesia for patients with muscular dystrophy. You know, for most of us, a surgery is pretty routine, but for these individuals, it can become a life or death situation if it's not handled with just absolute precision. So, how exactly do medical teams navigate a journey this delicate? Let's dive in. And right off the bat, you see just how high the stakes are. This quote plays it out perfectly. One of the most common everyday drugs in anesthesia, succinylcholine, is completely forbidden for these patients. It's a total non-starter. Why? Because it can set off a disastrous chain reaction, a flood of potassium in the blood that can literally stop the heart. This isn't just a suggestion, it's the bright red line between safety and catastrophe.
So to really get why that one drug is so dangerous, we have to understand the condition itself. Muscular dystrophy, or MD, isn't just one thing. It's actually a whole group of genetic diseases. But they all share a common enemy, the progressive breakdown of muscle. And we're not just talking about the muscles in your arms and legs. This weakness extends to the most critical muscles we have, the heart and the diaphragm, the very muscle that powers our breathing.
Okay, so here's how we're going to break this down. We're going to follow the patient's entire journey. First, we'll establish why this is such a high-stakes procedure. Then we'll go through the meticulous planning, which is kind of like a pre-flight safety check. After that, we're in the operating room, navigating the danger zone. Then comes the critical recovery phase. And finally, we'll wrap it all up with the absolute golden rules of anesthesia for MND.
You know, for most people, anesthesia is routine. But for patients with MD, it is anything but. Their muscle cells, already fragile, are hiding a major vulnerability. It means that standard, everyday anesthetic drugs can trigger a really devastating and pretty unique complication, one that most medical teams will rarely, if ever, see.
And this right here is the main villain of our story: anesthesia-related rhabdomyolysis, or ARR. When this gets triggered, the patient's muscle cells they rapidly self-destruct, dumping all their contents into the blood. This floods the body with potassium, leading to that hyperkalemia we talked about, which can stop the heart cold. And what makes it so tough is that it can look almost exactly like a more well-known crisis called malignant hyperthermia. But here's the key. While the symptoms look the same, the cause is totally different and tied directly to the patient's muscular dystrophy. So with risks this huge, you can't just show up on surgery day and hope for the best. Nope. The safety mission, that pre-flight check, it starts weeks, sometimes even months beforehand. This is where the real foundation for a good outcome is laid. And this is not a one-person show, not even close. You're basically assembling a dream team of specialists. The anesthesiologist is at the helm, sure, but they're working side by side with cardiologists for the heart, pulmonologists for the lungs, neuromuscular specialists who know MD inside and out, even gastroenterologists to manage things like aspiration risk. And the ICU team, they're in the loop from day one, because that's likely where this journey ends. And this team has a very specific checklist they go through. First, a deep dive on the heart with EKGs and echoes. Second, they focus on optimizing the lungs, because those weak breathing muscles are a huge liability. Third, they prep the GI system. And fourth, they run a whole battery of labs to get a perfect baseline of where the patient is at before they even start. Now, during that long assessment, there's one number that everyone is laser focused on: the forced vital capacity, or FVC. It's basically a measure of pure lung power. And if that number dips below 50% of what it should be, that is a huge red flag. It tells the team there's a really high risk of problems after surgery and that they need to plan for some serious support. Okay, and this part is just brilliant. They don't just find risks. They actively train the patient to beat them. Before even setting foot in the hospital, patients are taught how to use breathing support machines, like a non-invasive ventilator. They even practice with a device that helps them cough. It's literally a dress rehearsal for recovery. They're getting the tools and the training before they'll ever need them. All right, all that prep work is done. The team's assembled. Now it's game day. We're heading into the operating room, the danger zone. And in here, success comes down to following two absolutely non-negotiable rules.
Rule number 1 is all about what you avoid, those trigger agents. That means succinylcholine is off the table. Those inhaled anesthetic gases, like sevoflurane? Nope, not happening. So what do you do instead? That's rule number 2. You prefer the safest possible technique, which is total intravenous anesthesia, or TIVA. You're using IV drugs like propofol, completely sidestepping all those known triggers. But look, just giving the right drugs is only half the battle. You have to monitor their effects with insane precision. For these patients, any muscle relaxants have to be tracked with quantitative monitoring. This isn't just a good idea, it is mandatory. You cannot guess when the patient's muscles have recovered. You don't eyeball it, you measure. And this point is so critical, it's literally written into the official guidelines from the American Society of Anesthesiologists. It says you do not, under any circumstances, remove the breathing tube until that monitor, a train of 4 monitor, shows a ratio of 0.9 or higher. That number is everything. It's the objective, data-driven proof that the patient is strong enough to breathe again on their own.
Okay, the surgery itself is over. Everyone can relax, right? Wrong. Absolutely not. The period of highest risk has just begun. The recovery phase demands the exact same level of focus and systematic planning as every single step that came before it.
And just look at how carefully this is choreographed. First, they confirm that magic number, 0.9. Second, they don't just pull the tube and walk away. Remember that NIV machine they practiced with? It's waiting. The breathing tube comes out, and the support mask goes on just like that. And third, they immediately use that cough assist device. It's a perfect, seamless, supportive handoff. Now, once they're in the ICU, the surveillance continues around the clock. The team has a watch list. They're constantly monitoring the heart for any rhythm problems. They're watching the urine for any signs of that muscle breakdown we talked about. They're doing aggressive therapy to keep the lungs clear. And before any food or drink passes their lips, a swallow evaluation is a must. So we've walked through this entire intense journey, from months before the surgery to the recovery in the ICU. What does it all boil down to? If you had to distill this entire complex process down to its very essence, what are the golden rules? Rule number 1, and it is the most important one: avoid the triggers. At all costs. No succinylcholine, no inhaled anesthetic gases. Period. This is the absolute bedrock of safety. So what do you do instead? Rule number 2. You always prefer TIVA, total intravenous anesthesia. It's the safe pathway that avoids all of those dangerous landmines. Rule number 3 is simple. You cannot manage what you do not measure. You have to trust the data. Objective numbers from a train of 4 monitor aren't a luxury. They are a non-negotiable requirement. And finally, the 4th rule: this is a team sport. None of this happens by accident or in a vacuum. These amazing outcomes are only possible because of that meticulous, collaborative, multidisciplinary planning that starts long, long before surgery day. You know, when you step back and look at the whole picture, this isn't just a protocol for one disease. It's a masterclass in how to manage extreme risk. It's a blueprint for safety. And it leaves you with a really big question, right? How can this level of foresight, this systematic, team-based planning, be applied to other incredibly complex areas of medicine to make things safer for everyone?